Scalp is a soft tissue which covers the calvary of the skull. It extends to the supraorbital margin in front, external occipital protuberance and superior nuchal line behind, and to the zygomatic arch on each side where it merges with the temporal region superficial to the temporal fascia. Let me explain. So anterior margin, it starts from here, superciliary arches or supraorbital margin, then it extends into the external occipital protuberance and in sideways till zygomatic arch. So it is the extension of scalp. So now we'll discuss about the layers of the scalp. This is the cranial vault or skull. Below it, brain is present with dural venous sinus and other structures. Above the cranial vault, fifth layer of scalp is present. There are 5 layers in scalp. Fifth layer from above or first layer from below, the pericranium. It is actually periosteum. It is the outer periosteum of the skull and loosely covers the bones except at the sutural lines, because sutural lines it is continuous with the endocranium through the sutural membrane. And one clinical importance is there: if any collection of fluid beneath the pericranium, that will produce localized swelling in the form of cephalohematoma or traumatic cephalohydrocele, which assumes the shape of the related bone. That means if the swelling present in the parietal region, then the swelling will take the shape of the parietal bone. Now the second layer from below or fourth layer from above is the loose areolar connective tissue. This is the second layer from the below, and from above it is fourth layer. It has some clinical importance. So it is fourth layer from above, and this region is called, this layer is called dangerous area of the scalp. Dangerous area of scalp. Why? Because it contains emissary veins, and emissary veins connects directly into the intracranial sinuses. So any infection in this layer, it will spread through emissary vein to the intracranial sinuses, because the emissary veins are number 1 minus valve, matlab valveless. Second, first is it is valveless. Second, it directly communicates with the intracranial sinuses. Directly communicates with intracranial sinuses. So this layer is clinically important, and it is actually consists of loose areolar tissue, and it forms a potential space beneath the epicranial muscles. Above it there is epicranial sheath is there, epicranial aponeurosis. So it is a potential space in between epicranial aponeurosis and pericranium. So next layer above the loose areolar connective tissue is the Galia aponeurotica. Is the third layer. It is a fibrous tissue which connects occipitalis muscle and frontalis muscle. The skull contains 2 muscles. In front of the scalp, 2 valleys of frontalis muscle, and behind 2 valleys of occipitalis. In between these 2 muscles, frontalis and occipitalis, a fibrous sheath is there, that is Galia aponeurotica, and each side it extends as a thin membrane superficial to the temporal fascia and is attached to the zygomatic arch. This Galia is sensitive to pain. Temporal extension of the aponeurosis gives attachment to the auricularis anterior and auricularis superior muscles and occasionally to the temporoparietal muscle. So its extension from frontalis to occipitalis and sideways temporal extension to the anterior and auricularis anterior and auricularis superior muscles and occasional to the temporoparietalis muscle. And as I say, this Galia is sensitive to pain, and the wounds of the scalp gape only when the Galia or epicranius is divided transversely. So the next layer above the epicranial aponeurosis is the dense connective tissue. It is the second layer from the above. It is composed of close network of fibrofatty tissue and connects firmly the overlying skin and underlying Galia aponeurotica and epicranius muscles. So above its layer of skin is present, and below it epicranial aponeurosis is present, and it is firmly adhered to the skin and firmly adhered to the epicranial aponeurosis. And actually these three layer skin, the first layer of scalp from above, it is skin, second dense connective tissue, and third epicranial aponeurosis. These three acts as a unit. And epicranial aponeurosis, it actually movable because of the action of the occipitofrontalis. So this three layer acts as a unit. The dense connective tissue contains large blood vessels and nerves of the scalp. The walls of the vessels are adherent to the fibrous network. These are the fibrous network, and the blood vessels are firmly attached. So in case of any injury is there, as because of the firm attachment of the blood vessels to the dense connective tissue, retraction of the blood vessel is very difficult, because if you consider this is blood vessels and these are the fibrous tissue that is firmly connected to the blood vessels. If there is any injury, so the connective tissue will pull the blood vessels, the half of the blood vessels, in the opposite directions. As because of this, retraction of blood vessel is difficult, so bleeding is more. In case of injury in this layer, bleeding will be profuse even from minor scalp injury. So this layer is rich blood supply is present. In case of avulsion of large area of the scalp and that is connected by narrow pedicle, when replaced and stitched, will heal with little loss of from slogging. So its healing power is very fast as because of the rich blood supply. So we'll discuss about the next and last layer, fifth layer from below and first layer from the above, that is skin. This layer is skin. As you know, the skin of scalp contains different hair follicles, sebaceous glands, sweat glands. So hair follicle, sebaceous glands, sebaceous gland, sweat glands, etc. And scalp is the common site for the formation of sebaceous cysts. There is a clinical importance. Sebaceous cyst is the very common in the scalp. So these are the 5 layers of the scalp, starting from above skin and last pericranium. So in a nutshell, all the 5 layers are skin, deep connective tissue, epicranial aponeurosis, loose areolar connective tissue, and pericranium. Hope you like this video. Thank you very much.